identification and prioritization of health technology, preparing to dress for the slide, not for the ride. And to show you that we are prepared to dress for the slide, we brought a little something that my colleague, Mr. Damini, will show you. Here we go. So we brought a proper gear, and we hope at the end of today's session, you will feel that you are also prepared for the slide and not just for the ride. Now, my name is Wanruti Isla from HITAP. I am honored to be the chair for today's session, which will start out this three-part webinar series in collaboration between UNDP, ADP, and HITAP. We have exciting schedule for all of you today with speakers from around the world. So without further ado, please allow me to introduce the organizer, the brains behind this great webinar series, Mr. Leslie Ong from UNDP and Ms. Alia Luz from HITAP. Leslie is a program specialist at UNDP, supporting the implementation of ADP. He has led several successful webinars, so I'm a little bit nervous as he set very high standard, but I am also honored that I get to introduce him today. His partner in crime is our very own Ms. Alia Luz, an experienced project associate with management and research team of HITAP International Unit. Alia has worked with many country partners around the world to support everyone's goals toward an evidence-based society.
And as Dr. Wanruti mentioned, I support I am part of the United Nations Development Program, and I support the coordination and implementation of the Access and Delivery Partnership Project. So now I would like to just spend a couple of minutes to briefly talk to you about the Access and Delivery Partnership. There are, as you may know, there are a number of processes and capacities across what we call this value chain of access and delivery that more or less need to function efficiently and cohesively to ensure that new health technologies, and when I say new health technologies, I mean medicines, vaccines, and diagnostics. So we need these functions to be efficiently and cohesively functioning together, so that we can make these health technologies be affordable. We ensure that they are quality assured and safe, and also be made available in a timely manner to those who need them. These functions, as you can see in the infographic there, they include the regulatory system, and market authorization processes of health technologies. They also include procurement, price setting, and supply chain management, overarching policies, legal and governance frameworks, and of course, what we'll be talking about today, the cost-effective selection and prioritization of health programs and technologies. So for those of you who may not know, the Access and Delivery Partnership, or ADP, is led by UNDP, and we work in collaboration with WHO, TDR, and PATH, and we are funded by the government of Japan. The partnership aims to strengthen key institutional capacities, systems, and policies across this value chain to promote the introduction and scale up of new health technologies across a broad range of health programs and disease programs. And with the COVID-19 pandemic stretching health systems to almost breaking point in many of our countries right now, the resilience of this value chain becomes ever so important. So for today's webinar, and as well as the rest of this webinar series, it's going to highlight several of these critical components of the value chain. And it also at the same time highlights the core focus of the collaboration between ADP and HITAP in supporting countries in strengthening their capacities for prioritization and selection. So now I'd like to pass over to Alia to tell us a little bit more about what's coming up for the webinar series. Over to you, Alia.
And welcome all to this webinar series. As I was saying, this webinar is actually a three-part webinar series. As we are dealing with the pandemic, sweeping the world right now. It has exposed some of the vulnerabilities of health systems, and now more than ever, the use of evidence is needed in our in decision making in all parts of the in all parts of the healthcare, the life cycle of an intervention. So this webinar series has 3 parts. The first is identification and prioritization. The second is procurement and price negotiation. And the last is implementation and monitoring and evaluation. So keep an eye out for the other 2 webinars. And so we're looking forward to having you in those as well. So this first webinar, what are the objectives that we thought of for this first one? We wanted to understand what systems have worked in the past, so the how and why of prioritization, why we need this kind of system in place. We also wanted to explore different approaches that have worked in the past and what's happening currently, and what considerations should be taken in place. For example, political aspects, stakeholders, etc., that might have an impact in the prioritization process. And finally, how it's been applied in our country partners' settings and in our own setting. So we hope that this can be a way for us to share knowledge and learn together from each other. So the outline of our webinar we have a fairly packed agenda today, and we're looking forward to learning a lot from you and from our speakers. So after this, we will have a kind of a very theoretical background on the priority setting process. Then we'll see this applied in Ghana's priority setting. Then we'll hear about what the impact of politics is on priority setting, especially in the time of COVID-19. And moving on to that, like how it's looked like in terms of the application of, for example, guidelines for prioritizing critical resources. And finally, the latter half of our webinar today will be on an exercise that we're going to be experiencing firsthand to see the trade-offs of different types of priority setting methods. And so we can see what is the importance of having a good kind, or what would work well for different settings in terms of prioritization. And finally, we'll end it and look forward to the rest of our webinar series. So I'd just like to welcome our speakers. Dr. Wan Rudy, who is our chair, will definitely be introducing us all to you. So keep an eye out for that. And we'll learn more about everyone in the next couple of hours. But we also want to get to know you before we start. So I'd like everyone to go on this website called www.menti.com and key in the code 9319699, and we'll go on a little journey to get to know each other.
Nine 577-391.
All right, so if you can see our Menti here, there are a couple of reactions on the side. Oh, I'm seeing someone sending me a heart. Thank you. All righty, so we're gonna move on to the first question on our Menti. Which country are you from? Amazing, we have a lot of folks from the Netherlands. So if you can see, the bigger the words are, the more people there are who have inputted that word. All right, amazing, thank you everyone. So now I'd like to ask you what interested you about this webinar. Why did you decide to join? All right, we're seeing some words from our participants. Priority setting, so a lot of folks want to know about priority setting, a deliberative process, learning from country experiences, learning gaps. I'm a part of the ADB team. Thank you for joining us. Priority setting and LMICs, process, decision making, assessment of human rights impacts of choices. Wow, that's a very interesting reason for being part of the webinar. Want to know about HTA and priority setting in healthcare delivery? Great. We hope we can show you a little bit more about that. Great. So we're going to move on to the next one. In 2 or 3 words, how would you describe the way your country makes investments in healthcare? Ooh, I can hear everyone thinking ad hoc. Ooh, that's very interesting. Political. Irrationally, wow. Scanty, so maybe they don't make many decisions, so it doesn't happen. That's very interesting. Mysterious, so it's like a black box, right? You don't really know what they decide, how they decide. Political influence. Oh, explicit priority setting. All right, this is great. Evidence-informed deliberation, that's amazing. Implicit, interesting. So this is kind of similar to ad hoc as well. Systematic, that's good. Historical, lacks transparency of public-private partnerships. Prioritize health needs and budget. This is very interesting. We have a lot of people saying that it's very political, so it's great that we're going to talk about this later on. Based on the need with stakeholder involvement, based on resource and epidemiological trend. This is really great. So we can see there's a range of different ways. Some of the ones that are emerging are ad hoc and political, and some are with evidence, and some are implicit. So there are very different ways that people have, or countries have conducted priority setting. And that I saw another one called historical, which may also be like based on what you've done in the past. Great, great. This is really lovely. All right, so now finally, we'd like to know a little bit about some of the concepts that we may be presenting to you today, and want to know if you are familiar with them or unfamiliar with them before this day. Oh, okay, some folks are very, very familiar. All right, some folks are less familiar, for example, with political economy theories. A lot of folks very familiar with fair choices and quality. It's great, we actually don't know, this is good that a lot of folks are familiar with quality, because we're gonna talk about quality later on. Health technology assessment. Oh, we see some folks may not be familiar with health technology assessment, for example, even quality and even political economy theories. So you can see here at the end, there's some folks who said zero familiarity with this, zero familiarity with deliberative priority setting process. But we see there's a nice distribution. So we hope that we all learn a little bit during the webinar, and that some of these new concepts will pique your interest and will bring more learning and discussions in the future. So let's get into it.
Thank you, Leslie, and thank you, Avia, for a very interactive way to begin. Earlier, I said that we have speakers from around the world. And as you have seen in our Menti, we also have people joining us from around the world. So thank you for spending your very early morning, middle morning, afternoon, evening with us today. So as Alia said, and I do have to listen to her because she's sitting right beside me, let's get into it. So to help us start it, the first presentation with the title covering all the bases, the priority setting process. We were very lucky to have a physician and a professor of medical ethics from the University of Bergen in Norway, who firmly believe that priority setting for health should aim for the greatest number of healthy life years for all, fairly distributed. Please help me welcome Professor Ulla Norhem.
Thank you very much. And thank you for this nice introduction. I'd like to start by saying that I've been impressed by the work of HITAP, the work that you do in Thailand and in the region for many, many years. So I'm honored to give this talk today. Thank you. So next slide, please. So I plan to talk a little bit about why priority setting is important and the key considerations for priority setting. And I'll end with a discussion of the boundaries of priority setting. Next slide, please. So I would define priority setting as the ranking of services, and sometimes at the clinical level, the ranking of patients. So if you have a diagnostic test for COVID, for instance, you would often rank patients in terms of symptoms or other characteristics. My next reason for why I think priority setting is important is that many countries, as you described in Mentimeter also, have ad hoc decision making or follow historical trends, or reason why priority setting is important. In many countries, the elites influence priority setting, or it's done very ad hoc or based on historical trends. And when new diseases show up, or we see developments like more NCDs coming up, I believe there's a huge improvement if a country can move to more systematic priority setting. You could achieve huge health impacts, and you can improve the fairness of the system. Next slide, please. So I think UHC is a good context to see priority setting within. And you all know this cube illustrating how not all countries have universal coverage, but countries need to move in 3 directions to include the whole population, to reduce co-payment, and to decide which services are covered. And this is that dimension where priority setting comes in. And I was honored to chair a WHO commission on, or a committee on making fair choices on the path to universal health coverage. And we made some recommendations for fair and efficient priority setting, and that's what I will talk briefly about now. Next slide, please. So I think we should discuss both the scope, the criteria, and the process for priority setting. And I'll start with the scope. So next slide, please. I think it's important to think about universal health coverage and the priority setting process within that kind of reform to include both treatment and prevention, diagnostics and rehabilitation. So everything that the health minister is responsible for. For priority setting for better health in a population, you might even go outside the health sector and think about intersectoral interventions. But within the UHC context, we usually talk about those responsibilities that the Minister of Health are responsible for. I will talk mostly on health, essential health benefit package design, but there are other approaches also. Some countries like Ethiopia has just recently completed a full revision of their essential health benefit package. Other countries might, and many countries in Africa has done that, looked at what kind of services within the primary care level are most important. Other countries are especially concerned about emerging NCDs and wants to revise and define how to scale up essential services for NCDs. And HITAP and many other organizations, and we'll hear more from Ghana also later, also have institutionalized health technology assessment, where one typically will look at single health technologies and their place in the healthcare system. But However one does this, I think it's useful to think of services being prioritized as of high priority, medium priority, and low priority. And this is so because no country can afford to prioritize all possible and effective services. I come from Norway, a quite rich country, but we also limit access to some new and very costly cancer drugs, for instance. So there's always a struggle to assess and define what kind of services should be included among those that are universally provided to everyone. Next slide, please. So in the Making Fair Choices document, we recommend 3 criteria, and many countries will have to decide for themselves what kind of criteria they would base their priority setting process on. But I know of no country that hasn't included cost effectiveness, for instance. And many countries use cost effectiveness as their main criterion. I believe cost effectiveness is important because it's a way to identify how to maximize health impact in a population. And I'll talk more about cost effectiveness. But I've been especially concerned about equity also. So in the Making Fair Choices document, we say that in addition to cost effectiveness, you need to look at also who are the worst off and how do new technologies, new services benefit the worst off. And you can define the worst off as those that are most severely ill, so the worst off in terms of health, and also those who are the poorest or disadvantaged in other ways. And this means that in addition to cost effectiveness, you need to consider equity or fairness or priority to the worst off. And there might be a trade-off here. So if you want to improve the equity of the system, you might have to sacrifice some health benefits because it might be more costly to reach and help the worst off. But if you have a country and policy goals that also include equity or fairness, that is a trade-off that you might have to add. The third criterion we proposed is financial risk protection. It's difficult, but we know that some services are paid out of pocket, and it might push people into poverty if they have to pay a lot for these services. And that might be a consideration for including some services into the package. But then it's extremely important to be aware of that there is a trade-off between financial risk protection and cost effectiveness. So you might have to sacrifice health to provide a financial risk protection. And I'm sure we will discuss trade-offs more today. Other countries have included more criteria, especially burden of disease. But remember that cost effectiveness, cost per DAL averted or cost per QAL gained, is a measure that says how much we can reduce the burden. So indirectly, the burden of disease is also included in this first criterion. In Ethiopia, where I've been involved together with Dr. Getachew and Dr. Alemayo, who is also on this call, they decided to include 7 or 8 criteria. So it's possible to include more criteria, but the more criteria you use, the more complex the decision-making process will be, and it will be less transparent and perhaps less accountable. Next slide, please. So I'll just mention 2 commonly used tools for priority setting, and I will not go deeply into this, but cost effectiveness analysis will help you to identify services that will give or provide large health benefits for the least cost. And the analysis aims to identify the incremental cost effectiveness ratio. So you look at the added cost or the net cost and the net health gain. And it's often expressed as cost per DALI or cost per QALY. Quality is quality adjusted life years. And the graph to the right shows one example from DCP3, where several services are ranked from the very cost effective, that are services that cost less than $10 per disability adjusted life year averted, to services that might cost up to $1,000 per DALI. By using this ranking list, you can identify the highest priority. But remember that you also need to take into consideration equity and priority to the worst off, and financial risk protection. An extended cost effectiveness analysis is a new method developed by DCP and Stéphane Verguet and Dean Jameson and others, which looks at both equity and financial risk protection. So instead of just looking at averages, as in cost effectiveness analysis, it's possible to identify how different income quintiles, for instance, will benefit differently in terms of health and also in terms of financial risk protection. And at the end of this slide, I'll show references for those of you who are curious about this new method. Next slide, please. In addition to criteria, it's very important, I believe, to implement fair and legitimate processes for priority setting. And we recommend that they should be evidence-based, they should be open and transparent. One should provide reasons for priority setting, and there should be mechanisms of complaints. And for those of you who would like to read more about this, I recommend Norman Daniels and Jim Sabin's book here. Next slide, please. Another nice source of information is the Center for Global Development publication called What's In, What's Out. And they provide this very nice overview of one type of processes in 10 steps that can be established. So I also recommend this book. For establishing a process, it's good to define the methods and the criteria, and to identify the kind of services you want to assess, collect new evidence, undertake appraisals and budget impact assessments, and very importantly, deliberate around this data and evidence input, because this is not purely a technical exercise. You need to make judgments incorporating fairness and public considerations. There should be public participation in this process leading up to decisions. Translate these into resource allocation, implement and monitor, review, learn and revise. So these are basically the 10 steps recommended in the book, What's In, What's Out. Next, please. So let me end with this slide, reminding you that there are boundaries to this process, and priority setting creates winners and losers. It's very politically sensitive. There are strong interest behind some patient groups, not others. There are often historical budgets that are hard to change and move. And this is a complex policy process that I know that Jesse Bump will talk more about later today. Remember also that it's not enough to define a list of high priority services. They need to be implemented, a link to financing mechanisms and procurement mechanisms. And these are topics later on in this webinar series. And my final slide next will summarize. So I think the key message from my little talk is that think about priority setting aiming to maximize population health, distribute health fairly, and with financial risk protection. With these 3 goals, you will achieve a lot. And useful tools are cost effectiveness analysis, ECA, and evidence-based transparent processes. Thank you very much.
Thank you very much, Professor Ulla. That was very informative and insightful. So now that we have the basis covered, we may want to build on the foundation. And for this next part, please join me to welcome Dr. Brian Asari, who is a senior technical advisor at the Pharmacy Directorate, as well as the country coordinator for health technology assessment with the Ghana Ministry of Health. He is serving on several committees and working groups to support prioritization of health technologies. Dr. Brian will be sharing with us about Ghana priority setting process. Please help me welcome Dr. Brian. Dr. Brian?
Hello, one.
Hello.
Yeah, thanks for having me. Yeah, so I would be speaking to building of a foundation, and I think that the title is just apt for the presentation. It is truly foundation building, and all the issues that come to play do apply. Next slide, please. Yes, so the scope of this presentation cuts across, I'll be doing some history, and then I'll be doing some process guidelines for Ghana. I'll be highlighting some of the catalysts for the processes in country. And then I would also be giving an instance of priority setting, specifically for hypertension in Ghana. Thank you. Next slide. Yes, so far back as 1988 to 1996, in terms of the history, Ghana has been on the process of trying to use evidence to inform treatment guidelines. I highlight this because this is a low-lying fruit that we could actually get some visibility and some outcomes within the health system so far as the use of evidence is concerned, because guidelines are used across country to treat at several levels of care, and it's a key target for evidence-based approaches. Next slide, please. Then from 2000 to 2014, all the way to 2017, especially 2010, you would realize in the Ghana story that that was when modern approaches to evidence informing guidelines actually started. Next click. Yes, okay. So in all these processes, the highlights for where HTA or evidence informed medicine became strong was 2010, 2017, and even 2020 in the face of COVID-19, when all our consulting partners were locked in their various countries. We had to be in Ghana and develop a response to COVID and actually come up with treatment, provisional treatments based on experimental, very limited data and evidence. But all this is pointing to the fact that we are actually on a course for an increased demand in terms of a country-led, evidence-based, context-driven consensus outcomes and consensus-based decisions so far as the application of evidence is concerned. This is just a snapshot of where the country is in this particular area of applying evidence. Next slide. So what happened in 2010, which I said was a unique year, is that, next slide. Yes, we were set on course through Bill and Melinda Gates Foundation funded projects. It was the Better Medicines for Children project that was led by WHO. And then that sought to build capacity using an approach of train and develop. So we had exposure to evidence summaries, how to grade evidence, and targeted things around maternal and child health. Chlorhexidine was there. Malaria was a severe malaria was a mortality driver for children. So that was also a priority. Pneumonia was a priority. And because of that, amoxicillin dispersible tablets, and then artesunate was on the agenda. And through that, we were able to actually update the 6th edition of our treatment guidelines using evidence summaries through this particular initiative that is published. And I think participants and the audience can follow up on that particular work that was done in Ghana in 2010. Next slide. So the evidence process became part of the national medicines process, national selection process in Ghana, and that was quite worth mentioning. Now, then from 2016 to 2017, a major study was done, a major piece of work supported by ADP Path. And this work is what defined the landscape for institutionalization of ATA in Ghana. It has 11 key recommendations, technical working group, to have a steering committee as well as a technical working committee, and then to have the technical working group start with guidelines and then a reference case for ATA. Of course, build capacity, have clarity in terms of how we can leverage legislation to support ATA, and then also have a cost recovery mechanism to support the evaluation processes. The doing of an ATA incurs a certain cost. In as much as you want ATA itself to be cost effective, we needed to find a way of having some levels of cost recovery that sustains the process. Then we also had to seek impact on procurement, pricing, reimbursements, EMLs, and so on and so forth. So these are the recommendations that actually laid the foundation for the setup of the institutionalization of ATA in Ghana. The first target was the ATA strategy that this informed. Next slide. Then in 2017, we had the very first full-blown ATA model with support from IDSI. That was a hypertension model, which has informed the 7th edition of our standard treatment guidelines in implementation at the moment. Of course, that ATA prioritized calcium channel blockers, diuretics for newly diagnosed uncomplicated cases of hypertension. And that has been very, very important for us as a country. With the ATA conducted and implemented. Now, at the time we did this particular ATA, we did not have the structures that we have now. It was fairly easy to do this, but the challenging part is actually having to establish the structures for ATA and using those structures to conduct ATA. And that is where we are now. Our cake is actually cut for us, and then we are actually rocking the boat from here. Next slide. Next slide. Then we have the Norwegian Institute of Public Health also coming on board. The focus there is capacity building targeted at the technical working group. And the NIPH is also collaborating with the University of Ghana to provide technical assistance to the ATA working group as well as the secretariat. And that is actually focusing on short-term, medium-term, as well as long-term capacity building strategies. Next slide. Of course, HITAP has also played a key role in the capacity building. I must say that personally, I have even sat through training programs organized by HITAP. I remember the collaborations with the National University of Singapore. I remember vaccinology trainings in India. And these have been very, very useful for us, especially even both of them. I could highlight the vaccinology. It played a role in our response to COVID, where we had to model some of the viral SIRS models to actually see and predict some of the case levels and so on and so forth. So these have been very, very useful for us. Next slide. Beginning the actual challenging process was the establishment of the various governance structures for ATA. So this is a joint picture where we have our senior officials from the MOH, we have the Minister of Health inaugurating both the steering committee, the secretariat, and then the technical working group for ATA. So these are the human beings who are driving ATA in Ghana. Next slide. Of course, what are these structures supposed to do? It's supposed to do the governance work. The technical working group is focused on technical issues. The secretariat is playing a coordinating role and also managing partnerships and networks, as well as private sector and other stakeholders who are related to ATA. Of course, all this is happening within the state governance mechanisms that exist. The context is that we've had new geopolitical regions in Ghana now. Our regions have increased from 10 to 16, and now we needed to prioritize health infrastructure and services within all these regions. Our medicines policy is also making a clear direction for ATA and linking it with pricing, procurement, financing, as well as universal health coverage. We have an AMR policy in Ghana now, which seeks to build an economic case for investments into antimicrobial resistance, associated with a national action plan that's requiring about some $21 million over 5 years to implement. We also have emergency response to emerging disease with associated budget shocks, as well as the need for a comprehensive health system-based approach. So within all this, this is what actually introduced the weight that ATA tries to respond to in Ghana, and the scope is cut out for us. Next slide, please. A summary of the ATA strategy. Governance is at the center. We have agenda setting. We are developing guidelines. We are resourcing and tooling the ATA Secretariat. We are trying to mobilize resources and funding. We will definitely implement ATA that come. We will have to communicate our ATA both to high-level audience as well as low-level audience in terms of civil society, in terms of parliamentary select committees on health. We are collaborating with our international partners. We are building capacity. Next slide. So in terms of laying the foundation of a building, the specific actions that are taking place in Ghana, if you look at it from the base, we have, like I mentioned, earlier interventions around evidence summaries associated with capacity building. Of course, there has been an institutionalization study, and then there's a test case for hypertension. On top of that, we had to lay another layer of governance, and that is where we established our steering committee, technical working group. We have their terms of reference, meeting norms, as well as a strategy. Building on top of that, we are currently working on our process guidelines for ATA, setting up a criteria for ATA. We will be doing a reference case. Currently, a skills gap assessment is ongoing. We are collaborating with our partners. That the next immediate step for ATA in Ghana will be looking at the data that informs ATA, because in our country setups, sometimes access to data for ATA is challenging. So our strategy spoke to that, and we'll be working on that. Above that, we see funding issues, methods, guidelines, legal assessments, more technical work, communication, and so on and so forth. At the top, we see impact assessment, because we want to assess, when we do an ATA, what kind of impact are we making in the system. Next slide. All the greens, back, previous slide, please. Yes, all the greens are where actions are currently ongoing. The reds are yet to start. So in terms of our ATA strategy, a lot of work has started. We just need to keep the momentum on, use our networks to ensure that we are able to carry this through. And I'll be congratulating our partners who are supporting us to actually drive this process forward. There are a lot of opportunities for ATA work in Ghana as well. Next slide. This then is the summary of what the Ghana process looks like as at today. You see, steering committee, the XC starts the process, look at the development of the policy and strategic direction. The steering committee also sets criteria. As was mentioned by Prof in the previous presentation, the criteria is defined by the steering committee in Ghana. Of course, they will approve the topics. And then when it comes to the analysis sits within the technical working group. And they are able to co-opt expertise into the technical working group as and when they need. So all the technical alliances that we have, we're able to co-opt any expertise that will be required into that process. Of course, an appraisal would have to be done for an ATA. Steering committee will deliberate on results, and then final recommendations will come from the steering committee in terms of decisions. And then it could be communicated, and there's a place for appeal where the decisions could be appealed, and then the technical working group will have a subgroup for an appeal to address appeals as well as communication. Of course, all this is managed by the Secretariat by way of process management. And of course, there's also the stakeholder engagement processes to make sure that we are not moving alone. We are moving with all our stakeholders as we go along. Next slide, please. Again, we are using an evidence deliberative process in Ghana, and that is what we have adapted into the ATA process, as well as the decision-making criteria that you are seeing now. So we see the role of the Secretariat, we see the role of the 3 governance structures that we have, as well as the implementing agencies, and the need for appraisals, appeals, and communication. We put a reference here for those who would want to follow this particular approach to the ATA process definitions. Next slide. Of course, I'll quickly highlight what we have done for hypertension. It was informed by the disease burden, as well as hypertension being a cause driver for NHIA. We look at cost effectiveness for drugs that reduce blood pressure, and specifically hypertension. The population was patients with hypertension who are not having complications. The interventions are the main 4 categories of drugs for hypertension, and we looked at it compared to no intervention. And we looked at heart attack, stroke, heart failure as outcomes. Next slide. Not to be too technical, but basically this is the model for those who would be interested. This is the model that we have used to do that piece of work, and these are the data sources. You would see that we had to assume 50% of patients have access to services. These are some of the gaps that we wanted to bridge using our ATA data sub-project to be able to ensure that the data that is required, of course, we know that we will not get every data that we need to inform an ATA, but we want to be able to reduce the cost of access to data, that we don't have to commission studies all the time to be able to get the data that we need. But we're able to actually be cost effective in our approach to doing an ATA. Next slide. Yes, so after everything, this is how the ISA distribution looks like. We can see where the calcium channel blockers are located, as well as where the diuretics are located. And that is where we have the best in terms of cost per DALYs avoided. And that is why we were able to update our guideline to prioritize calcium channel blockers and diuretics as the first line for newly diagnosed, uncomplicated hypertensive patients. Those 2 were focused on because you realize that the AC inhibitors and angiotensin receptor blockers, beta blockers were dominated in the analysis. Next slide, please. Next slide, please. All right. So, of course, we want to acknowledge ADP path. We want to acknowledge NIPH, WHO, HITAP, and within ADP path, we will acknowledge, of course, UNDP, the government of Japan for their support. NIPH is also there. DFID, as well as IDSI, are all acknowledged, and they have all played key roles in this particular story that we tell on behalf of Ghana. Thank you very much.
Thank you, Dr. Brian. So we're now going to pause and take a couple of questions. On the group chat, you see that there are many interesting questions coming in. So please do send more questions, and remember, you can also do the raise hand option as we are monitoring that function as well. So if it's okay, perhaps Alia, we could take one question for Dr. Ula and one for Dr. Brian. Yes. Okay. So first, perhaps Professor Ula, this question is from you. Is for you. I'm going to read out the question. So, hi, Professor Ula. Thanks for sharing the concept and practice of health priority setting. As I is the person who asked the question, although I also interested in this question too. As I heard from you that there are many global initiatives for health priority setting. So I wonder whether low and middle income countries need to develop this kind of evidence themselves, or can they borrow the evidence generated at the global level? If LMIC use of global evidence, what they need to do to ensure local acceptance of such evidence? Thank you. Professor Ula. Please
Thank
respond.
you very much. This is a very good question. I believe that countries need to build this expertise themselves, at least so that they can review and systematically assess evidence from other countries. And it's not easy to translate evidence from other countries to your own, but there are methods now being developed to do so. But I strongly believe that to influence policymakers in your own country, you need to build this expertise and actually do some of these studies themselves, either on cost effectiveness, extended cost effectiveness, or HTAs. At the same time, it's possible to look at the global databases like the Tufts Registry for Cost Effectiveness Analysis, the Disease Control Priorities Network publications, and WHO that are now developing a new platform for accessing this evidence. And I've written more on this in a paper that I shared the link recently on a theory of change for low and middle income countries. Thank you.
Thank you, Professor Ula. Now, yes, there are more questions, so please do send them along. I'm going to shift and ask Dr. Brian a question. It's a question from Edward Tuambarim. My apology for mispronouncing it. Do we have a threshold for deciding what is cost effective or not? Dr. Brian, please answer.
Okay, so we are still in the process of defining benchmarks in Ghana. We are doing a process guideline. The next one is actually a methods guideline, which addresses technical issues around HTA. So for now, we are leveraging the WHO standards for ISA calculations in relation with the country GDP. And that is what is the guideline for now, until we are able to adapt that into our country technical HTA manuals and guidelines. That is what we are using currently. So that will be the answer. Yes, of course, there are other questions. I don't know. I'll just pause until you throw it at me. Well, if I can take advantage of your silence, I would speak to the issue around the big data. That is, of course, very important for Ghana. What we actually have now is that we leverage our NHIA data, claims data, to do some of the work that we are doing. Of course, that restrains the perspective to the HTA, to the NHIA perspective, the insurance perspective, but we'll eventually want to do societal perspectives, and therefore we are looking at having a price or costing system well established in Ghana, also looking at services that are provided and the volumes of consumption of these services also being provided, and having a way of actually have some kind of integrated platform that picks information from our clinical data systems, our pricing data systems, and make it available for the HTA secretariat that feeds into the technical work that the TWG is doing. So, of course, the data discussion is ongoing, and we really, it's a decision, it's a strategic area that we have to look at. Thank you.
Thank you, Dr. Brian, and also Professor Ula for your question now, and for your answer. So as there are more questions, if you prefer, please do feel free to chat and provide answer, but we will have time to come back to a few more questions. But Alia give me a very difficult job, which is to make sure we move forward with the agenda. So now to introduce this next speaker, a question came to mind, which is, if you want to know how dedicated a person is to support our society in sharing knowledge during this challenging time of COVID, don't ask them a question, but rather make a request for him to present in the webinar at 5 a.m. in the morning. Then you know how dedicated this person can be. We are absolutely fortunate to have with us the Executive Director of the Takemi Program in International Health and lecturer on Global Health Policy at the Harvard T.H. Chan School of Public Health. He has a very impressive bio, which I'm not going to capture all, but he is known as the expert in political economy of global health, and also to us, a very, very good friend and colleague. To discuss politics, principle, and priorities, please help me welcome Dr. Jesse Bum.
Thank you, Juan Rudy. That's a very generous introduction. Thank you for having me. It's been a real pleasure. I've worked with HITAP for a decade or so now, and I always love collaborating. So whether it's in the middle of the night for you or for me, surely one of us is getting up and it's always worthwhile. So here's what we'll do today. Let's go to the next slide if we can. I'm gonna work on these three things. It's just a quick series of logic. I'm going to try to situate priority setting for you in a larger context. And then I'll talk about how you manage political economy processes. And then I'll talk about how priority setting institutions have a larger role. So next slide. I'm showing you here one version of national performance. And I've chosen two countries. That's the United States on the right. The scales there are very different. This is showing you the accumulated daily cases for COVID-19 over the last few months. So over there on the right side, the USA has had 6.3 million cases and counting rapidly with about 190,000 fatalities. And on the left side, over the similar time period, South Korea has had just 21,000 cases with 341 fatalities. And I'm offering this to you just to show that you can measure national performance in a lot of different ways. And I think very few people would look at this and say that the country on the right has done a reasonable job compared to the country on the left. Even though South Korea's population is, roughly 1/6 the size, there's really no way to compare these that would be favorable to the US. So think of this as one dimension of national performance. Let's go to the next slide. Political economy began, and I know some of you have questions about what this is. I'll just give you a few quick points and we can return to it if you have more questions. But political economy began as this question of national performance, particularly what balance of government and markets and citizens' rights produces the best national performance. And that's been interpreted in a lot of different ways over the last couple hundred years, including in distributional issues where it's a study of who gets what, or in contests of interest where political economy really means power. Usually, however, when we're looking at national performance, most people look loosely at gross national income per capita and they figure richer is better. And as I showed you in those two slides, the two graphs of South Korea and the US, and I could have picked a lot of pairs of countries, income doesn't correlate well with performance on COVID-19. And it's for this reason, I think COVID-19 is an empirical outcome indicator of interest itself. Next slide, please. Therefore, it's not a proxy for anything. It's a direct indication of what you want. And therefore, you could say that national priorities are revealed in this performance. For example, did the country overall, and I'm speaking in general rather than with reference to a particular priority setting institution, but did the country overall prioritize things like individual decision making or personal liberties? Or did it prioritize social cohesion? That is, people agreeing on what to do, or collective safety? Did it pay attention to public health expert opinion? Or did it, look at evidence and arguments, I'm charitably going to say, from other sources? And priority setting processes may be unclear. It's not clear exactly how they work or exactly how they unfold, but the outcomes are revealed. Next slide, please. So I've made this quick chart to help you understand the kinds of decisions that get made in countries and how they move from one sphere to another. So down there on the lower left, I have two axes. I'll start with that. The vertical axis is individual choices versus collective decisions. And then on the horizontal axis, the left side is personal engagement and the right end is politically salient, meaning things that everyone in the country or many people care about. So there on that bottom left corner, you have private market transactions. They're individual transactions that are determined by purchaser and seller. They're not binding on anybody else. So this is often things like personal preference. If you want, you know, this flavor of drink or that flavor of drink or this product or that product, it doesn't matter to me as a disinterested party. It's like whatever you work out is fine. And private decisions are really simple, in part because they're very small, and in part because they respond to very direct problems that are solved between two parties only. And this is how momentum can build in the private sector. It's many people making similar transactions and identifying shared interests, whereas public decisions, which are binding on everybody, they're in the top right corner, they're very hard to manage because they're frequently contested. It suddenly matters to each person what other people do. And it's very complicated, it's hard to understand, and it tends to be dominated by either concentrated economic or political interests. So next slide, please. What tends to happen is that interest groups try to pull that government decision-making down in their direction. And the market failures of private transactions push interest groups toward the government, mainly because groups can't buy enough or they can't pay enough to get what they want, or sellers can't sell enough or charge enough. So you can think of in our sphere of health, the very common things are pharmaceutical company will make something expensive, they will recruit a patient group to demand it, and then they'll both go to the government and say, you pay for it. Similarly, interest groups that want something and can't afford it will go to the government. And that tends to move this sphere where normally governments would make decisions, or at least in theory, they make decisions about what's best for everybody. It pulls them down in that direction of making immediate choices that are good for a few, but maybe don't consider the rest of the population. So next slide. This has a lot of problems, this kind of decision making. It tends to be dominated by the stronger players that have either more money or more political resources or both. And it creates or increases inequalities because it's subject to market failures. It doesn't redistribute, it can't regulate itself, and it can't optimize over a broad population. So next slide, please. So here's what tends to happen. And this is part two, where you can think of priority setting institutions as an attempt to manage this political economy. And what I've done is just to zoom in on that top right corner, the government tries to make decisions, and there are all these lobbies. I've just listed a few here. They're often disease groups or interventions like remdesivir here or sofosbuvir. Like there's a lobby for each of these things, whether it's a condition like polio, a treatment like dialysis, a drug, or it's a disease like TB, or a process like ANC visits. Global health, and this is also true of national health, tends to balkanize itself into these little interest groups, and they all lobby separately. So next slide. HTA institutions such as HITAP or NICE, or in England, or there are many, or what OLA does in Norway, they tend to be envisioned as a political economy superhero. And I've used the Superman logo to symbolize. We could have made a super make or a super yacht or a super alia, because this is what these HTA or priority setting institutions, and I'm just going to use those synonymously for the moment, it's that they're supposed to make order out of all that chaos, evaluate options, calculate benefits, make public interest decisions, such as the most fairness or the most financial protection or whatever value system they want to use, and end that chaos. So next slide. They often use some of these tools like extended cost effectiveness analysis or cost effectiveness analysis. They provide advice to government, whether it's definitive like best buys or wasted buys, to use terms from a book that some of us wrote together a couple of years ago, or it's parametric depending on context. It's advice that clarifies choices, often manifested in a health benefit package design. So next slide, please. it's based on this idea. At its core, it's that reason will prevail. And in places such as Norway, where Ola was speaking from, it often is true. It's a very reasonable country. And in other places that are reasonable, this model tends to work very well, and it prioritizes the technical excellence of those institutions. It prioritizes the transparency or independence or other values. So next slide, please. But I wanted to show you this to say that reason doesn't always win. And a couple of colleagues and I, this is Sarah Bolongaita and Stefan Vergey, we've been trying to calculate excess deaths per capita over the COVID period to show how nations have performed differently. And I chose this subsection of our alphabetized results to show how reasonable Norway is, where the red line shows you there's almost no more additional mortality, whereas in Italy or Spain or the UK or the US, there's quite a bit more mortality than normally, and probably that's due to COVID-19. So next slide, please. And this brings us to the last part, which is that I want you to understand priority setting institutions as having the main function. The internal one that Ola was talking about is to make the right decision, but I'm going to say that their main function is actually external, and it's to manage these politics of making decisions, where to be nonpartisan or transparent, those are actually political statements. They're statements about how politics should be managed or adjudicated. In technical sophistication, it's only influential by political agreement. That is, people agree with one another that we should use that basis for managing our decisions. So next slide, please. What I want to propose to you as a closing thought is that priority setting institutions need to take this external political management role seriously, because sometimes they are neglected. Sometimes leaders, and the one of my own country is a good example, they don't care about technical evidence. Some citizens don't want to pay attention to best advice. So having a priority setting institution that produces the right answers is only part of the solution. It also has to manage popular expectation. So for this reason, I'm proposing a new kind of ECEA as enhanced constituency engagement analysis to promote transparency, fairness, and risk protection as societal values. And I want to encourage you to think about priority setting institutions as linked to others. So should they take roles, say, in the court by litigating positions that they feel strongly about? Should they offer testimony or lobbying as a formal part of a parliament or Congress? And should they engage the public to extend their own influence? By whatever means, I think is quite contextual, but these are ideas where you can imagine how priority setting could be ensconced in society as a whole, which would make it much more influential. So thank you very much for joining me at whatever time of day it may be for you. Thank you to my colleagues at HITAP and the other presenters and everyone who's joined us. So thank you very much. I'm happy to take questions, and have a good day.
Thank you very much, Jesse. That was very, very insightful. You know, when you finish with the side bump, usually I think we want to avoid side like that. But in this case, with you, we certainly want to work more with bump. So we do have time for any burning question. There are actually quite engaging and interactive discussion, especially around using COVID-19 vaccine as example. Jesse, you also get a nice message from Dr. Ula as well about the new definition for ECEA.
I'm glad he liked that. You know, I can see Dr. Yacht has commented in the comments there about the forecasted COVID-19 vaccine. And unfortunately, many nations, maybe even all of them, but certainly many, have pursued a competitive strategy where they try to get everything for themselves and then worry about distribution, both internally and externally. And I think most of us here would agree that That's probably the wrong way to do things. That's not prioritizing the values that we usually espouse. That's simply the more powerful will get it, rather than the most needy or the places where it might maximize health.
Thank you for that. There's also a question for Dr. Ule from Indonesia. The question is around how can we rationalize the price of COVID-19 vaccine, where government is trying to find shortcut to end this pandemic. Any additional response, Jesse?
So you're asking about how is this in the pandemic? Is this a time scale question?
Yes, so I think it's more around the concept of rationalization, right? And especially we look at the number of tries from COVID-19 vaccine right now. People are talking about how much vaccine would cost, but the amount of investment going into studies of trying to find this vaccine, giving that is not, it may or may not be more than 50% efficacy. So any additional thought on this?
Well, I mean, this is a tough topic, and the design of the vaccines themselves reveal something about the priorities they embody. So if you were making a vaccine that you really wanted to go to the worst off, it might be heat stable. It might be single dose. It might be long lasting. But insofar as I've followed those developments, they tend to be, the vaccines seem to prioritize the needs of people who could see a health system or a provider quite regularly. Maybe immunity would last 2 or 3 months and then you have to go back. There's so many choices embodied in the design of a vaccine that when you get to these other questions about who will get it or how will it be manufactured, a lot of these choices have already been made. And I think what we're doing now of, in a sense, letting the market sort it out and letting the most powerful countries grab their shares first I think it's totally disastrous.
Thank you for that. And perhaps we'll finish this Q&A session with one more question. I saw that Cecilia from ADP, you also have a question. Would you like to unmute and ask your question?
Oh, thank you, Dr. Wanrudi. That was a little unexpected. I was fumbling around with the unmute button. No, I think it was very interesting, just following up on the questions that I think Dr. Yot, and then I think Dr. Bump had also mentioned, just in terms of whether or not there might actually be a possibility of a more global approach towards priority setting when we're talking about the potential vaccine. And, if a competitive approach is being used by governments, is there a way to bring them together to try and figure out a more global approach? And I've also seen that Dr. Ole has, sent me a link, sent us all a link about the ethical framework for global vaccine allocation. But it'd be interesting to hear more from others in terms of, the global approach towards priority setting. Thank you.
I mean, I think that's a terrific question. And the answer is certainly yes. It's yes in theory, and then it's yes in practice, if by globe you mean people like us. So you and I and our friends at HITAP and everyone on the call here, I think we could quickly reach agreement about how we would distribute a vaccine. But the fact is that the global institutions are already designed with certain priorities in mind. For instance, there is no supranational authority. And that means that countries, they'll collaborate if they want to. Usually they don't want to. Right now, they don't want to. You could imagine in some universe where people like us are in charge, we'd say, okay, countries have to collaborate. But right now they're not collaborating. And the roots of non-collaboration run really deep. So for example, the governance of the World Health Organization was designed to be insufficiently strong to meddle in the affairs of the colonizing countries. It goes really deep, back into the 1940s when it was designed. The reason that WHO can't tell countries what to do is because those nations that designed it didn't want an international authority to meddle in their colonial or imperial relationships. And so if you ask now, could we? The answer is yeah, we could, but we're not set up to do it. Nations aren't accustomed to doing that. And that means the powerful nations. They have not wanted to subjugate their own individual interests to the larger global interests. So I'm going to give you a long run answer, which is, yeah, we can do it, we should do it, we should work toward it, and we can get there, but we're not there today.
Thank you, Jesse. I think that's a great way to kind of finish this short Q&A part. And couldn't agree with you more with how you nicely give us that concluding statement. There's still more discussion on the group chat, so please feel free to keep that going. At the same time, I'm going to bring forward our final speakers to wrap up this initial presentation. We're gonna be getting more hand-on exercise shortly in the second part of this webinar, so please do stay tuned and stay with us. So these next speakers is our very own high tapper, all the way from United Kingdom. Miss Rachel Archer is a project associate at HiTap, and her work has helped several countries by focusing on health system strengthening and supporting evidence-informed health policy making, again, in many low and middle income countries. She's going to be sharing with us today about her research during this COVID-19 pandemic on the Thai guidelines for prioritizing scarce critical care resources. Rachel, please take it away.
Thank you. Well, firstly, thank you so much for having me. So yes, I'm going to talk to you all today about Thailand's experience in developing a protocol for allocating scarce critical care resources during the time of COVID-19. I'm firstly going to give a bit of context, then I'm going to talk a little bit about the development process, I'm going to talk a little bit about the content of the protocol, and then I'm going to finish with sharing with you all a few lessons learned. Next slide, thank you. So as we all know, COVID has reached every corner of the world. And when responding to COVID-19, many countries have faced shortages in critical care resources. And when I say critical care resources, I mean ICU beds, ventilators, and also things like hemodialysis machines. And they face shortages because they're having to meet the needs of so many severely ill patients at exactly the same time. And expanding ICUs is not an easy endeavour, it's untimely, it is costly, and it requires major infrastructure investment. So what we've been seeing is many countries, predominantly countries across Europe and North America, have created guidelines for the allocation of scarce critical care resource to ensure fair allocation and uniform allocation across the country or across the state. And it's thought that explicit guidance can help relieve some stress from the actual bedside clinician. Next slide. So this has really hit the headlines there, with many stories about young doctors in Italy and also in New York having to what was described as playing God, because there was not guidance available to them, and they had one ventilator available and they had to decide what patient would get that ventilator. And it really did hit the headlines. Next slide. So looking at Thailand, so in the peak of the epidemic, and this was at the end of March, early April, the number of ICU beds had almost reached full capacity. So recognising this, the Ministry of Public Health put out a call for the creation of guidelines for critical care resource allocation that could be applied fairly and uniformly across Thailand. And they reached out to 3 technical bodies, HiTap included, another organisation called IHPP, and the NHRO. Next slide, thank you. So there were a few conditions for the implementation of this guideline. The first condition being that the agency in charge of responding to COVID had to declare it a national public health emergency. And the second condition was that we had to prove that we had exhausted all avenues for resource mobilization. And even after the expanding as much as we can, demand still exceeded supply. And now importantly, the protocol would not discriminate between COVID-19 patients and non-COVID-19 patients. So the protocol would be applied to anybody needing critical care. And this would be applied in both private and public health facilities. Next slide. Thank you. So we had really 6 steps in terms of how we developed the protocol, from step 1 being the literature review, all the way to developing 2 manuscripts, which we hope to publish in the next few months so that other LMICs can see how Thailand did this, because a lot of the guidance out there is from high-income country perspectives. So what did a middle-income country like Thailand do? So firstly, I'll speak, go back. So very briefly, we did a literature review and we looked at what the existing guidelines said and what the ethical literature said, and that really formed the basis of our draft protocol. But as we've heard with our previous speakers, what is very important is local context. So it was important then that we had interviews with health professionals to understand what was the current practice, what was the current challenges, and what could be enacted in reality. And when we spoke to health professionals, they said that there was no existing protocol of this nature in Thailand. So next slide, I'm going to talk a bit more about stakeholder consultations, because as we have heard, they form a very important part of priority setting. So we had 2 half-day stakeholder consultations where we presented our draft protocol. And the first group included medical and medical law experts, and the second group included policymakers and also individuals from the social sector. So we had policymakers, individuals from the media, and also predominant figures in religious groups. So next slide. Thank you. So I'm now going to highlight some of the main features of Thailand's triage protocol. And this was agreed upon with the 21 stakeholders that we consulted. So this is what we finalised with the groups. Next, thank you. So firstly, it was decided that in this context of a public health disaster where we have scarce critical care resources, the prioritisation of patients should be based on maximising the greater good. And this is what we deem a utilitarian model of triage. So in the context of health, we mean this to be maximising health benefit. So in the Thai protocol, patients would be assessed using objective and measurable criteria for clinical prognosis. And this criteria focuses on the short-term survival prospect of patients. So a patient with a higher chance of survival would then be prioritised. The protocol includes 4 tools that it recommends for assessing the patient. And the hospital can choose at least 2 of the following tools that I've listed here to assess the patients. And these 4 tools have been widely used across Thailand, and also the literature shows that they have a strong mortality, they are a strong predictor of mortality. Okay, next slide. Okay, so importantly, each hospital has a bit of flexibility to decide which tool they can use, and this is because we acknowledge differing local challenges. but they must apply the tools consistently across the patients and the cases. And obviously we recognise that there might be an equal score between two patients. So if this is the case, then a third and fourth assessment tool would be used for making that additional assessment. So interestingly, when we presented the draft protocol to the stakeholders, the research team presented two possible options that could be used as a tiebreaker. The first one was number of life years saved, and the second one was social utility. And these were two different criteria that we had seen when we were doing our literature review, but they were both disregarded from the stakeholders. So number of life years saved was disregarded by the stakeholders because the stakeholders said that this would discriminate against the elderly, and they said that this would discriminate actually against the male population because females have a higher life expectancy. And social utility, and what I mean by social utility here is it means prioritising somebody that plays a crucial role in the pandemic, and often this is, for instance, a health worker. So you would then prioritise them if you had to choose. But this was also disregarded, and this was disregarded because social utility is seen as subjective. So for some people, you might actually define social worth as a person being the breadwinner or the caregiver of a family. And for other people, everyone has equal worth independent of their social function. So both of these different criteria were disregarded. So we decided to stick to clinical outcome as the primary measure. And lastly, there should not be a cutoff score, used, and the patient scores should be compared. Next, please. Okay, so we also talked with the stakeholders and finalised information about the decision-making process. So when we were doing the literature review, there's a wealth of literature that says that the attending physician should not be charged with making this decision on who gets access to life-saving care, as this can be mentally stressful for that clinician. But then when we looked at the Then when we looked at the Thai legal framework, we found that that decision by law has to be made by the attending physician only. So we therefore couldn't have a third party that would make that decision. However, we did understand by reading the literature the benefit of having a supportive triage committee, or we called it a patient review committee, that could provide support to the attending physician about making these difficult decisions. So in the protocol, we recommended a patient review committee that would support the attending physician with this decision making, but also help communicate these difficult decisions to the patients and to the relatives. Now, who is included in the patient review committee is decided by the hospital director, but we said that at least 5 people should be included, and an odd number should be made up of an odd number so that we can avoid a split vote. And this could consist of doctors, nurses, social workers, or perhaps a respected figure in the community. Now, when patients are assessed differs in many guidelines around the world. So what we decided is that the patients would be assessed upon ICU admission, but also they would be reassessed during their ICU stay in case the condition of the patients changed, which obviously can and is often likely to happen. So they would be reassessed every 48 hours. Next, please. Okay, so what the research team did is we thought it would be very important to actually have a diagram of how this decision making would look in reality. So we have the start of the process where we're assessing patients for critical care, and then we look at how the patient review committee play a role in this, what the prioritization criteria is, and then how that final decision gets made, whether you provide or continue critical care, or whether you step down to palliative care. And importantly, the patient review committee and also the attending physicians need to note down the data and the decision in a patient registry, and this would then be reviewed by a third party. Next slide. Thank you. So we have the protocol ready to go, but since mid-April, the COVID-19 situation in Thailand has been improving. And I put here that on the 2nd of September, Thailand marked 100 days without any local virus cases, and we just recently had a local case. But that still stands because that's important to keep in mind when you're thinking about what the politicians are thinking when they're making these decisions. So the Medical Council and the Ministry of Public Health were then reluctant to legally endorse the protocol because A, it wasn't deemed as an urgent matter because the COVID-19 situation was improving, but also they were worried about what message they would send to the public if there was an improving COVID-19 situation, but then an announcement that a protocol based on rationing critical care resources has been enacted. The protocol would be, if there's a change in circumstance, legally endorsed if we have a severe surge in cases that are beyond the critical resource capacity. And what is very important is that when, I think this has been mentioned throughout as well, the importance of public engagement. So what is important is that when this is implemented, there needs to be intense communication with the public to enhance their understanding of why this protocol is needed and why it has been written the way it has, but also for public accountability, and a two-way communication stream would be developed so that we can get feedback from the public. And this is something that we've seen in the German guidelines, where they had a survey monkey and where the survey platform, and people could submit their thoughts on the protocol. And I think that, I'm not sure if that changed or not, depending on the feedback. Next slide. Okay, so 3 big lessons that we learn. Firstly is the importance of stakeholder and public engagement. This is a very sensitive issue, and it's so important that the protocol that's developed reflects the values of the given society, and also that the public understand why resources will need to be rationed in this circumstance. Secondly, it's very important to align with local context and legislation. So as we heard with the case earlier of developing a triage committee that would be charged with making that decision, we could not do that in the Thai context, even though the literature was telling us that, even though many countries around the world had done that. When we came back to the context of Thailand, it was not possible with Thai legislation. But we looked at what we could do to mitigate stress for the physicians in the context of Thailand. And also, my last point being that priority setting does not exist in a vacuum, and that we are not immune from political influences. As you have seen, that we developed a protocol, we were ready to translate the evidence into policy, and because of the political mindset, because of the improving situation, we couldn't enact the protocol. Okay, next. My references, I've done my job. And yes, of course, follow HiTap everywhere that you can. Thank you.
Thank you very much, Rachel. I really hope we get to work more together.
I hope so too.
So we do have actually a few interesting questions. If it's okay, I'm going to highlight 2 questions for you, Rachel, to answer before we go into a very short break with fun exercise, so that we can turn the table and give everybody hands-on experience of priority setting. But before we get to that part, I want to assure everyone that with the question that you left, even if we don't get to it, we are going to make copy of this and send to all the speaker, and all the information will be uploaded and shared afterward. Is that correct, Amir?
Yes, that's correct.
Okay. So Rachel, are you ready for your questions?
Yes.
Okay. The first one is from Emmanuel from Ghana. What the average time used for the critical assessment decision making before treatment is started?
Okay, so as I was discussing earlier, the patient would be admitted to ICU. So they'll be considered for ICU care, and then we would make that decision. Because we haven't yet implemented the protocol, I'm not sure on the time specifics in terms of how that would work with the patient review committee supporting and how fast that decision can get out. But then once that decision is made, they would get admitted to ICU, or it would be decided that they would step down to palliative care. And then every 48 hours, there would be a reassessment.
Thank you for that, Rachel. Another question is from Dr. Annabelle from Philippines. If societal benefit was the basis for prioritization, why do you think that the stakeholder rejected the idea of number of life years saved and social utility? So how is/was societal benefit operationalized?
Okay, so there's many ways to translate maximizing the greater good or maximizing societal benefit. In the case of the Thai protocol, we translated it as health maximization. So we therefore, and consulting with the Thai stakeholders, we wanted the assessment to be based on clinical prognosis. So we wanted it to be based on saving the greatest number of lives and therefore prioritizing people that had the highest chance of survival. So with that in mind, we therefore, and I say we as in the stakeholder group, rejected number of life years saved and social utility because they didn't fit in this clinical outcome bubble. So therefore they decided that was not appropriate for the Thai protocol.
Thank you, Rachel. And yes, there are more questions coming, and we will keep note of those. And to our speaker, please feel free to respond as well. So we are going to continue now into the next part. As we was doing a little bit of a dance, so we now want to build on the concept around balancing, but this time we're going to be balancing the trade-off. And Miss Alia Luz from HiTap, she's going to give us a crash course. Tell us a little bit more about what is it when you say use the term WALL-E. It reminds me of the cartoon, the robot WALL-E, but I'm not sure it's related. So what is it all about? We hear about cost effectiveness analysis as well. So how can they actually help us? So in 15 minutes or less.
Okay.
Thank you, Alia. Please.
Thank you, Dr. Wanrudi, for that lovely introduction. So welcome again, everyone. And so now we're going to do something a little bit different. We want you to be very involved in this exercise. So as Dr. Wanrudi said, we're going to be going through an Excel file. Don't be scared. We're going to go through it in detail. So before I start with the presentation, I'd like everyone to try and access our file so that you can get the most out of this session. So please do kindly download the exercise from the reminder email sent today. It's going to be at the bottom, which says download material. So you just scroll down, or you could also go to our registration website, www.hitap.net/webinar. Just put it into your internet address box and then scroll down, and then you're going to see in the bottom materials, exercise, and slides. So it's going to prompt you to enter some information before you get in, but just plow through it, and then you're going to be able to access our material for today. Okay, so now moving along, what we're going to do today is very timely a vaccine prioritization exercise. And our goal here is for us to kind of understand and appreciate some of the concepts that we learned in this webinar in a hands-on exercise, tackling an issue that would likely occur in the real world, and especially now with COVID vaccines in the discussion, we'll likely see this kind of consideration as well in the future. So what is our situation? We need to prioritize these vaccines in the coming year. So this is something that perhaps many of us who are policymakers have faced in the past and will likely face in the future as well. But in this situation, we are prioritizing 5 vaccines. So the first is pentavalent, then measles, BCG vaccine, PCV, and rotavirus vaccine. And we are prioritizing these vaccines for a childhood cohort of 200,000. So, you could bring in your own experiences. If you're a clinical doctor, maybe you have some ideas about this, but for our purposes, we're looking at this all as kind of like the same right now. And then we'll see a little bit more information later on. So who are you? You are a National Immunization Technical Advisory Group, or NITAG member. So you would be part of the group that's going to give recommendations to the government on which vaccines they should be prioritizing. And what is our issue? We have a budget limitation of $4 million. So that's our situation right now. And you can also see this information in the exercise as you take a look. So once you have been able to download the exercise, I'm going to type our webinar details as well here in the chat, so you could follow along if you want to download the exercise. But you're going to see an Excel once you open it up. And it's going to look like this. You're going to see first this beginning part where it says priority setting exercise. And that's the first thing you'll see on the Excel file. And as you scroll down, you're going to see these other items. But for now, we're going to focus on this top part. So kindly stay there. All right, so now we're going to look at the different ways that we could set priorities. And as you can see here in the bottom, we have 1, 2, 3, 4, 5, 6, 7, 8 columns. And these last 4 columns are the ways that we set priorities. So the first way we would say we've set priorities is this one, which is what if we had all the money in the world and we had no budget limitations at all? So we could choose whatever we wanted. So in that case, how would you make your decision? So we leave that to you as you go through the exercise. The second way is, what if allocation was left to our discretion with no explicit process? So as we saw earlier, like a lot of people said that the way that they've done priority setting has been very political in their countries. So this is something that you could incorporate here. So, there is no right or wrong here, but remember, you still have a limited budget of $4 million. So the limited budget kicks in here. Next, what if we chose the cheapest vaccines we can afford within our budget. So this is normally, for example, if you have let's say a procurement process that does tendering. Of course, it's going to be different here, but that's kind of the idea. Like, you choose your cheapest vaccine. It's going to be different here because normally you do tendering for the same type of vaccine, but in this case, we're looking at different vaccines for different diseases. So that's going to be this one. And you're going to be looking at the price per immunization here. Oh, and just to go back actually on the last one. So here you say random allocation based on limited budget. So this is our second way of setting priorities. The way we've thought about this is in terms of percentage. So what percentage of the $4 million US that you have are you going to allocate for these 5 vaccines? So finally, what if we accounted for the vaccine's value for money? Now this is gonna be the last column here, and we're gonna be looking at these, all 3 of these previous columns before the vaccine prioritization options start. And you're probably thinking, like, what does this mean? What are you asking me to do? What do these terms actually mean? So we're gonna go through a quick summary of what value for money is. So let's talk first about QALYs. So what is a QALY? This is something Dr. Wanrudi mentioned earlier. So a QALY is called a quality adjusted life year. So I think Professor Ula also mentioned this earlier, but what is it actually? So you can call it like the health gains from an intervention, at least in this particular case. The value of the QALY is usually between 0 and 1, with 0 equating to death and 1 to full health. And it is a standard measure to compare different types of interventions. So you can compare things like apples and oranges. That's something that a lot of people will say about different interventions. So you can see here the QALY per immunization. So you can see, like, pentavalent, you get 0.5. So that's halfway to full health. And you have rotavirus vaccine, which is less than like 10% to full health. So you can kind of see the gains you get from each of these vaccines. And now, what is this term, this dollar per QALY gains? So that's actually a concept that captures the value for money that we're talking about. It is part of health economics that is applied in economic evaluation. And economic evaluation basically lies in the root of this idea of scarcity, where we are dealing with limited resources. So our choices should maximize our resources and our health gains as much as possible. And so we're comparing different interventions to determine which option has the best outcomes or best value for money. So what does that look like? Let's say you're looking at this upper right-hand corner. You have an apple and an orange. And you have the cost of an apple is $1 and the cost of an orange is $1. But perhaps you get different, you have a different preference, or you have a different fullness level for the apple versus the orange. So you get fullness level of 1.5 for the apple and fullness level of 1 for the orange. So that means you're gonna get more bang for your buck if you buy the apple as opposed to the orange, because that's your personal preference. So that's kind of what we're capturing with dollar per QALY gains. So it's the trade-off between your monetary investment and your health gains. So for example, we'll look at the pentavalent example here, which has $20 per QALY gains. So that's actually your $10 cost of immunization divided by your QALY gains. So that's $10 divided by 0.5. So you get $20 per QALY gain. So that's how we came up with this table here. And when you make your decisions on what you're going to be investing in that's value for money, you'll be looking at the table called dollar per quality gain, but that value is taken from the first two columns here. All right, you're probably still thinking, I would love to learn more about this. This is very interesting. In that case, please do check out our website called Guide to Economic Analysis and Research. And there you'll be able to see some lovely mind maps that detail some of these concepts. And then you can have like a look at and learn more about quality and cost effectiveness analysis, ICERs, incremental cost effectiveness ratio, etc. All those lovely terms. And of course, follow us because then we can show you more. Now back to the exercise. So now we've gone through this beginning part, right? What we're asking you to do is for you to go through each section, each part of the prioritization, and you will be making your decision if you had number 1, number 2, number 3, or number 4. So these are all separate ways to make decisions. And then we can look at what the outcomes are. So in the section, if you scroll down the Excel, you're gonna see this part where the values of what you've chosen up here will show up. So you can see like how much you spent and how many qualities you gained in the section below. So I'm not gonna spoil the whole exercise so you guys can have a chance to play around with the Excel file, but we're gonna have our excellent TAs talking about this section in the bottom here, which you will see when we scroll down. But as I mentioned, you're gonna see your outputs from your decision making here, and you can compare the different ways to prioritize in the bottom.
To leave this next part of wrapping up the exercise and bringing us to a close for this webinar, please allow me to introduce a lecturer with the Department of Infectious Disease Epidemiology at the Imperial College London in UK, Dr. Hugo Turner, who has worked on a wide range of projects among many with the country with the goal to use health economic to support optimization and informing health policy. Dr. Hugo, can you hear me?
Hi, everyone.
Perfect. Please take it away.
So I was just going to briefly summarize the main exercise and then go into some wider discussion. So if you look at the spreadsheet in your graph, you'll see if you consider the third option, if we just use the cheapest vaccines, we would gain 46,000 qualies. However, if we allocated the budget randomly across the 5 vaccines, 20% each, we would gain 74,000 qualies for the same amount of money. So this example shows very nicely that just looking at cheap interventions does not lead to the best health gains, and it can be very inefficient. Now, in a perfect world where we had an unlimited budget, we could gain 156,000 qualies in this setting, but it would cost $7 million, which is almost double our budget. Thank you. So where this gets interesting is if we based our allocation not on the cost, but on the cost effectiveness, so looking at the cost per quality gained for the different vaccines and focusing on the ones that are most cost effective, we could gain 128,000 qualies for our 4 million budget. So we're not having the same benefits as we would with a perfectly unlimited budget, but we are still getting close for a lower amount of money. So I want to summarize here that using cost effectiveness for priority setting is not about saving money, and it's not about finding what is the cheapest intervention, but it's about trying to use healthcare resources that we have available in the most efficient way in order to maximize health. And this is really important, particularly in times of COVID, because we're obviously never going to have an unlimited budget or unlimited resources, but we can still generate significant health gains by using our available resources as efficiently as possible. And that's really the foundation of this type of analysis. So I think this practical really nicely shows. Can we go to the next slide, please? For some of our remaining time, I wanted to start by asking some of our partner countries who have volunteered to discuss how these concepts and cost effectiveness and priority setting can be applied for your country for around 3 to 5 minutes each. Do you have any volunteers before I pick on people?
Hello.
Hi.
Yes, so I think this activity, to the extent that it prioritizes amongst options and how resources are allocated, I look at it from, first of all, with the right data informing such an exercise, the principles that are being expressed here could actually be used to allocate resources to even Ministry of Health budget allocations and annual programs of work, if we're able to prioritize what options give us the best outcomes. The same principles could apply in that area. If we had, for instance, a limited budget so far as reimbursements are concerned, where we actually deploy our resources and what informs the allocation of budgets, it's also relevant for this exercise. I think even right to the level of a health facility, these sort of principles also do apply when revolving drug funds are being managed at that level. So from a very high level, at the level of ministries of health, right down to health facilities that provide services and need to prioritize within a limited budget, I think that all these competencies and skill sets and principles are applicable in the context of even a lower middle income country like Ghana. Thank you.
Do we have any other country volunteers on the line?
Hi, Hugo.
Hi. Hi, Frederick.
Hi, nice to see you again. I'm from Indonesia, Frederick. I think Dr. Brian already raised some good points. For me personally, I think several points that I learned through the exercise and from all these the conversations are: one, that actually no budget limitation is never happened, only in theoretical and in our dream, but that never happened. The second one is cheapest, not always the best. I think that's the point you also raised, but usually not the best option. Not in this priority setting, not even in our personal life. Cheapest, not always the best, usually it's not. Then longer roads, I prefer to use the term of longer roads. I mean evidence-based, usually leads to better decisions. And in the end, it leads for a wider or higher social benefit. The fourth point is data is highly needed. clinical data, economic data, policy data, regulation data. I think one participant raised this question, preferably from my own country. So then the policymaker will not ask, but this is data from that country or that country, but it's better to be from our own country. I think this is also vital in these times of COVID-19, because you can see all the government, all the parties like the government, Minister of Health, communities, patients, industries, they have their own interests and all are meddling in the middle. So I think us as the scientists needs to provide a good and reliable data for them then to be considered. I think that's one thing that me will personally go with the HTA agency in Indonesia, especially in my university for the future. Thanks, Igor.
Thank you. Can I follow up with Brian and Frederick? How difficult is it in your country at the moment to get sort of good data on the costs and health effects of interventions that are actually from your country and not from other settings?
That's I think I saw some people from the Ministry of Health also and the HTA body. I think we just started, so there's less than 100 HTA studies being conducted. Our university, so it's still so scarce, but we are keep inviting people from the universities to do HTAs, and I think we are heading to the good direction. But as always, at this moment, funding are directed to the COVID-19 pandemic instead of studies. But I think there are some funding agencies and collaborators also in high-tech. I think we also will, we are going to do a DCE study on COVID-19 vaccine. I think we'll also in collaboration with high-tech. So for policymakers as the respondent. So I think it is one good data that we will produce after that.
Okay.
Yes, so I think data is a big discussion, and when it comes to ATA, data becomes, I mean, it's a whole ballgame because it's quite data intensive, we all know. In our country settings, I think that, yes, access to specific direct data for key questions and key context that we want to move in has always been a challenge. If you look at it, especially on the effect side, for any intervention, the fact that you would find a direct study or a direct research that has been conducted in a similar setting that you can just pick and bring into your local setting becomes a bit difficult. And I think that there's opportunity in strengthening the data systems in countries, number one, and also looking at how best we can leverage certain data sets as proxies for the sort of questions that we needed to answer. Because I think the demand for data would be endless. And as we face new questions or questions that have not been answered before in our context, it would always be a challenge. But if we can leverage proxies with meaningful, robust assumptions that are realistic, then that could also be a way to go around this data issue. So I would talk about strengthening data systems in countries, as well as trying to leverage on realistic and practical proxies that could approximate to the kind of data sets that we need that we don't have. Yeah.
Thank you.
Thank you.
So I'll just,
Hi. Hi. I'm Emmanuel from Ethiopia. I was wondering, like most of the issues that you raise in economic evaluation or in cost effectiveness studies are the issues of data system. We are facing the same problem here in Ethiopia, I mean, most in developing country. I was wondering, like, if you can share your experience with a costing data system you have. How can we adapt to it to here, and of course in other countries too? Thank you.
Sorry, could you repeat the question? You asking about costing a data system or costing an intervention?
For the costing intervention, having a good data system, you know, to have a good record of what you are doing and using it as the end for the cost effectiveness analysis.
So I'd like to add that costing studies are often underrepresented, and they are obviously very important for economic evaluation. So I always try and do a local costing study rather than apply it from other countries, but that's not always possible. And there's particularly, you get a lot of countries where there's a lack of data.
Okay, so it has been a really great session. Thank you so much, everyone, for joining us today. Now, I think people say when you are in enjoying mode, time went by quickly, and I think that's how we feel today. I cannot believe how quick the time has passed. But like most things, all things must come to an end. But that's actually not true for this part, because we are going to be back for part 2 and part 3 as well. And now to wrap up, do not worry, I will not be the one who conclude. I actually have reached out to all the speakers to share their final take home that they would like to share with everyone who attend today when they're thinking about identification and prioritization of health technology. What comes to their mind? A take-home message that will be in the Twitter format, meaning it got to be short and sweet, or they could also share a title of a song that remind them when they think about this take-home message. So we'll see what each speaker would like to, how they would like to summarize that take-home message. So with that, could I first ask Leslie to share your take-home message, please?
Yes, I don't know how brief I can be, certainly not as brief as the Twitter format, but I would just like to thank all the speakers and all the participants to begin with. This has been incredibly interesting for me. One thing that was quite apparent to me was to achieve maximum impact. This process of prioritization needs to be quite well integrated and implemented across all decision-making related to delivery of health services. You know, as part of an integrated and cohesive approach to promoting health technology access. And an important consideration for countries when conducting this prioritization process is for it to be more than merely a technical or mathematical exercise, and for it to take into account the other perspectives and metrics in terms of determining value. So not only that, I think it needs to kind of link to and influence decision-making in other functions and sectors within the health system and beyond, meaning, you know, this management of the political economy that Jesse spoke about before. So anyway, that's my 2 cents worth. Thank you.
Thank you very much, Leslie. So next, Dr. Brian.
Yes, I think that from an LMIC perspective, the process of institutionalization of ATA is not a very simple, straightforward thing, especially when you are trying to build the structures that you need to actually start the ATA cycle from beginning to the end. And driving that as a country-led process is a key priority. but it's not an easy road to thrive. It's a very challenging road, and I think that LMICs would leverage all the networks that are available to ensure that that is done, because prioritization is key for our LMIC context.
Thank you, Dr. Brian. Next, Rachel, final take home in the song.
Okay, I won't do a song, sorry to disappoint, but I'll try and be short and sweet. So the COVID-19 pandemic has created a scenario of scarce medical resources, and this has been at an unprecedented scale. And it's highlighted to us the importance of legitimate, fair and explicit priority setting. However, rationing, as we all know, is a reality of health systems globally, even when we're not in a pandemic, because resources are limited, but wants and needs are unlimited. So the development of fair and explicit priority setting mechanisms should not be placed on the back burner during non-pandemic times, and we should consciously and continue to develop such mechanisms.
Short and sweet. Thank you, Rachel. And Dr. Hugo?
Hi, everyone. Just to finish that, cost effectiveness is not about saving money or finding what's cheapest. It's about trying to use healthcare resources in the most efficient way in order to maximize health. And that to really do a good economic evaluation, you need to know and understand the local setting and interventions you're looking at. And that's just as important, if not more important, than the economic and theory and the models you're using. Thank you.
Thank you. So that brings us to a close. Now, as a reminder, a recording and material from today will be made available. So please stay tuned and or feel free to reach out to the organizer, to us at HiTap and ADP anytime you have any other question or would like more information on any topic. I would like to speak on behalf of the speaker that please also feel free to reach out to the speaker if you have questions for them as well. Nobody took me up on finishing up with the song. Do not worry, we're not singing. But, you know, I think from the discussion today and given the situation we are in, it's really a reminder, if we're not already knowing it, that we are in this together. So the song that came to mind when I was thinking about this was the song that we are the world. And there's a one sentence that says that there's choice that all of us has to make. And when we all have to make choice, we hope that you think about priority setting. So with that, that concludes our session for today. Thank you again. We hope to see you soon in part 2 and part 3. Please continue to stay safe. Once again, good morning, good afternoon, and good evening. Thank you.